My background in the area of healthcare law and choice started in 1990. Let me think about this. Time passes. 1992, working with Planned Parenthood. And I was Director of Public Policy for Planned Parenthood for 15 years. I went to law school where I had the opportunity to study with Catherine Tucker, who was the National Legal Director for Compassionate Choices. And I was able to take her end-of-life class. And it was a powerful learning experience. I worked with her as an intern during law school, and then subsequently worked in Washington, D.C. as policy director for the National Compassionate Choices organization. I also worked as a Blair Butterworth Fellow, sponsored by Compassionate Choices and Planned Parenthood in Washington, D.C., which gave me a year over the past 18 months to think about the issues that were emerging under the umbrella of hospital mergers and how it affected not only reproductive choice, but also end-of-life choice. And to think about the history of that problem. It's easy to react when a problem emerges. It's hospital mergers. Well, 10 years ago it was pharmacy refusals, and before that it was abortion refusals. It's all the same problem. It just pops up here in one context. It pops up over there in another context. And if you are reacting to the particular problem that's emerging, you may miss the fact that the problem is actually much bigger and that you may have allies and resources available to you that you may miss unless you define the problem in its full context. So that's sort of the theme of my comments today, is to think about the issue of individual choice and the fact that if you cannot find a doctor or a hospice or a nursing home or a hospital who will honor your choice, then all of the work that went into the Death with Dignity Act and the Living Will statute really becomes meaningless for many people in this state. So part of the context is thinking back to 100 years ago. And really the roots of these religious refusals goes back to military objection, Civil War time. Come back forward into the last 50 years, 60 years, and you have the Griswold decision around contraception. And that spurred the first modern healthcare refusal law in Colorado that allowed public health workers to refuse to dispense birth control. A couple of years later, you have the push for the legalization of abortion. Before Roe v. Wade, people think, well, the abortion refusal issue came up with Roe v. Wade. No, it actually came up maybe 3 years before, when Washington State and a few other states legalized abortion. In order to get that law through, the advocates and their legislative supporters wrote into the law a provision allowing people to refuse to provide abortion. Provisions allowing facilities to refuse to perform abortions. So that's the second wave of refusals. And over the last, so that's 1970 here in the state. So over the last 44 years, there has been this ongoing political fight back and forth over how do people, get the rights that they want in statute, and how do other people get to assert their religious or political or moral objections. After the abortion law in 1970, you had the advanced directive law in the state. So the reproductive rights people were so busy focusing on making sure people had access to abortion, they weren't really paying attention to what was going on at the end of life. And so the end-of-life folks wrote into the advanced directive law because they had to. It was a political compromise. It was necessary to get the law passed. Another refusal provision that allowed certain people and facilities to refuse to honor your advanced directive. So yeah, you got the right, but again, if you can't find a doctor, You can't find a hospital, can't find a hospice, can't find the nursing home. What do the words on the paper mean? Not a lot. So it has built since then. When I first dealt with this issue, it was 1993 when we had healthcare reform in the state of Washington. And the issue was everyone would have insurance, and the women's groups worked really hard to make sure every insurance policy would cover birth control and abortion. So of course, to get that passed, they wrote in another refusal clause that said, yes, the insurance companies had to cover this, but nobody had to do it. The insurance company, as long as they weren't a religious insurance company, could refuse, but other insurance companies had to somehow make the services available if it was part of the benefit package. So you can see that even in our own state, not even counting the federal laws, the federal hassles and compromises and funding restrictions and litigation like the Hobby Lobby case, it's a web of provisions that allow people to decline to provide services that they object to. So the challenge for Compassionate Choices and Planned Parenthood and the ACLU and the other advocates is to navigate their way through those clauses in the law and to use other tools in the healthcare insurance, the health facility licensing. There are tools available in law that protect people's rights to care, protect their ability to give informed consent for services. So Margaret will talk more about what the advocates are looking at. But I think Washington is, again, at the forefront of this issue. While the press has talked about hospital mergers, I think we all know it's much bigger than that. And particularly when you're dealing with the end-of-life concerns, we know that it is hospices and nursing facilities that we also have to address. And so I hope that, I'll turn it over to Margaret, that those of you who care about this issue will get involved with the advocacy groups who are trying to find the regulatory and legislative solutions to ensure access to services and to actually assure that individual rights are protected here in the state. Thank you.
Thank you for having me. My name is Margaret Chen. I'm a staff attorney at the ACLU of Washington. I have been working on the issue of hospital mergers at the ACLU for the last 2 years. And I think over the last 2 years, in collaboration with Compassionate Choices and other advocacy groups, we've made a lot of progress in educating the public about the issue of hospital mergers, which Theresa had alluded to. Just for folks in the audience who aren't aware of what we're talking about when we say hospital mergers, I just want to give you a sort of a brief sort of description of what we see as the problem of hospital mergers. With federal healthcare reform, we are seeing a lot more consolidation in healthcare facilities and entities that provide healthcare to the public. A lot of the purpose of the consolidation is to increase efficiencies in the provision of healthcare, make it a more streamlined experience for patients. What is happening across the country and has been happening in Washington State at a rapid pace is that it just so happens that Catholic healthcare systems, Catholic healthcare corporations have significant assets and are frequently the affiliation partner that is stepping in to provide assistance to smaller private or public hospitals or healthcare providers in Washington State. For those of you in the room, some recent transactions that you may recall are Swedish and Providence here in Seattle, Highline Medical Center and Franciscan Health System down in Burien, Harrison Medical Center and Franciscan Health System out in Bremerton, United General Hospital in Cedro Willie with Peace Health, and what used to be the Inter-Island Medical Clinic on San Juan Island closed, and Peace Health constructed a new facility which is subsidized by the Public Hospital District in San Juan County. With all of these affiliations and consolidations with Catholic healthcare corporations, The ACLU and Compassion Choices and other organizations have become very concerned about the changes in the scope of services that are being offered to the public as a result of a Catholic healthcare partner becoming in charge of the operations and management of these healthcare facilities. As some in the audience may be aware, Catholic healthcare providers are required to follow the ethical and religious directives for Catholic healthcare services. It's a 42 pages. It is a lengthy document of instructions, essentially directing Catholic providers, people employed by Catholic providers who may not even be Catholic themselves, in terms of the types of services and information and referrals they may offer patients. As you can imagine, the ethical and religious directives restrict access to sort of beginning of life services, birth control, vasectomies, tubal ligations, but they also impact people's end of life choices. For example, Catholic healthcare providers will not comply with an advance directive that is contrary to Catholic teaching. Catholic healthcare providers frequently prohibit their employees or individuals who may have medical privileges to use their facilities from participating in Washington's Death with Dignity law. We understand that when Harrison Medical Center affiliated with Franciscan Health System in Bremerton, Harrison's CEO said that its providers would no longer be allowed to participate as a physician under Washington's Death with Dignity law. So that has restricted access to death with dignity for patients across the Sound. In terms of what the ACLU, Compassion and Choices, Planned Parenthood, and other advocacy groups are doing, we are looking at this issue as a statewide issue, and we're looking at potential opportunities for a statewide solution. For the last, I want to say, year and a half, we've been looking at opportunities both in terms of regulatory reform and as well as potential opportunities for legislative reform. I want to tell you a little bit about some of the efforts that our organizations have made in the past several months. One is that the Department of Health is responsible for overseeing transactions in healthcare. The regulations had formally stated that if there is a sale, purchase, or lease of a hospital, the Department of Health must review that transaction, and the entities applying must receive state approval prior to moving forward. Many of these transactions, such as Harrison, Highline, and Swedish, bypassed Department of Health review by characterizing their transactions as something other than a sale, purchase, or lease. In recognizing this gap in the coverage of state regulatory oversight of these transactions, our groups wrote to the governor, and the governor in turn responded and ordered the Department of Health to look at its regulations and consider whether or not they need to change the scope of the regulations to encompass the types of affiliations and other corporate transactions that were occurring that were not technically a sale, purchase, or lease. Those regulations are currently the subject of a lawsuit that is pending in the Washington Supreme Court. The Washington State Hospital Association, which is the I would say professional association for acute care hospitals in Washington State, challenged the new regulations, which encompass the types of transactions that Harrison, Highline, and Swedish engaged in. And a Superior Court judge agreed with the Hospital Association. The state of Washington has appealed that lower court ruling to the Washington Supreme Court, and so that case is ongoing, and we're hopeful that we will be able to urge the Washington Supreme Court to uphold the new regulations which ensure broader coverage of the types of transactions that healthcare entities are entering into, and to ensure that these are subject to state oversight, because it's important for the state to ensure that when healthcare entities are affiliating or consolidating, especially in this new economic landscape for healthcare, that the government ensure that patients have continued access to care and secular entities aren't sort of cutting back services because at the demands of their proposed Catholic partners. Our groups have also been looking at hospital licensing. One great success was to enact regulations also with the Department of Health, which requires hospitals, many hospitals which formerly did not have anti-discrimination, reproductive, and end-of-life policies to actually formulate these policies and post these policies on their website so that you as a healthcare consumer can find out and know exactly what services are and are not offered by your community healthcare provider. Right now, our groups are in the process of reviewing those policies and hope to be able to shed some more light on these policies because some of these policies we found are not written with the greatest amount of clarity. And of course, what's the use of a policy that you post on a website that does not exactly make clear for the average consumer what exactly you can access at that facility. Our groups have put together a checklist that we think would do a better job at ensuring consumer transparency in healthcare services. And those checklists are available on our website. We encourage you to use that checklist to go to your healthcare provider to seek answers about the kinds of services your healthcare providers will or will not provide to you based on their own policies. As Theresa mentioned, this is a multifaceted issue that touches not only on sort of corporate law and healthcare law and how these entities are entering into legal agreements to become related, as well as sort of hospital licensing and various forms of government oversight, but it also involves other aspects of healthcare, including insurance. What good is it that your insurance will cover a particular service if you can't find a service provider within your geographic region? And so that is an issue that Theresa has done quite a bit of work on. We call this network adequacy, that your insurance network must have adequate number and type of providers within the plan that's offered to the public. And we're looking, and so that's another area in terms of insurance that we're looking at to ensure that, as a way to ensure that no matter where you live in Washington State, you have access to all lawful healthcare services. So those are some of the things that the ACLU, Compassion Choices, and other groups have been working on over the last several months. There is, of course, still much work to be done, and so we're looking forward to the new legislative session to continue to work with legislators, policymakers at a statewide level to explore different ways to continue to work on this issue. Thank you.
Thank you, Margaret and Theresa. I really appreciate the background. I get a lot of questions about how did this happen? How is it that people get to deny our end-of-life wishes, or how do they get away with that? And so I think it's good to get some perspective on how these refusal clauses, notice I'm not saying conscience clauses, these refusal clauses, how do they come into law? How did it become legal for providers to decline to provide the services that many of us think that we're entitled to? So my part of the program is about ensuring that your end-of-life healthcare choices will be honored in an era of expanding religiously controlled healthcare. Now, we're in Seattle, and many of you are probably served by secular providers, Group Health, Virginia Mason, Evergreen. Providence is sort of secular-ish, since its affiliation with Providence. And so you're thinking, well, why should I be concerned about this? My providers are not affiliated with the Catholic Church and subject to the ethical and religious directives that Margaret was talking about. Well, let's say you're driving to Portland or Vancouver, and you have an auto accident. If you have an auto accident in Whatcom County, you're going to Peace Health St. Joe's Hospital. It's the only hospital in the area, and it's a Catholic-owned and operated facility. If you have an accident in southwestern Washington, you're going to Southwest Medical Center, a large medical center that was acquired by Peace Health many years ago. And when you go into these facilities, if you're in a trauma situation, you don't have a choice. You can't simply kind of pop up and say, oh, I don't really want the Catholic one, I want the secular one. You go to the closest emergency room. You're going to get emergency medical treatment as soon as possible. So we're all potentially subject to Catholic health care and restrictions that come with Catholic health care at the end of life. There are many things you can do to ensure that your end-of-life choices will be honored both at secular facilities and Catholic-controlled facilities. One is to obviously make advance directives, and I'm probably preaching to the choir a little bit here. But documenting your wishes, putting them in writing, having them witnessed and signed and notarized if you choose, it's not required in Washington. And especially using Compassion and Choices of Washington's directive, which combines a living will with a durable power of attorney for health care, will help ensure that your wishes get honored. Now, most important is naming an assertive health care agent, someone to speak for you when you can't speak for yourself. And also naming not just a primary agent, but an alternate agent in case your primary agent can't be reached. If your primary agent is backpacking in Africa with no cell service, then obviously you want someone else to be able to come make your medical choices for you. Having an assertive healthcare agent is really important. The importance of talking about these wishes with your family can't be overemphasized. You know, there are so many people that make these documents and name a healthcare agent. They never talk to their family, their spouse, their other loved ones. They don't talk to their physician, and sometimes they don't even tell the healthcare agent that they've been named to make their medical choices for them. There's a study in Oregon several years ago that found out that 30% of people who are named as healthcare agents were people who were completely unaware of it. So your healthcare agent is, is somebody that you need to know and be close to and needs to know your values and your wishes and your spiritual and religious beliefs. This is extremely important. Now, some of you have large families, and I urge you to try to meet as a family to discuss your end-of-life wishes. And there's a couple of reasons for this. One is that it's not unusual at all for a single member of a family to throw a wrench into the works when you're trying to discontinue life-sustaining treatment, for instance. Just saying, I don't agree with that, or I don't want to do that. And physicians are so fearful of being sued, of the liability around providing medical care, that they'll back off a little bit. They may not proceed with even honoring the patient's documented wishes if there's a very loud, assertive family member saying, you can't kill Grandpa, you can't stop that life-sustaining treatment and kill my grandpa. So it's important to get families together. One of the reasons to do that is also a good form of peer pressure. If you have a family member who was at this meeting who suddenly says, well, I don't agree with that, the rest of the family can gang up on him and her and say, wait a minute, you were there when Dad said he wanted this or didn't want that. We were all there, we all heard him say it. So that's really a powerful way to kind of keep people in line in terms of your end-of-life wishes. If you can't get people to agree to your choices, including the choice of, let's say, death with dignity, at least try to get them to what I call a point of loyal opposition. And by that, I mean, at least get them to say, I won't interfere with what it is you want to do. I don't agree with it, but I won't interfere with it. And sometimes that's the best you can do. You are not going to probably change an evangelical, born-again Christian's perspective on death with dignity. But you may be able to get her or him to say, well, I don't agree with that, but I'm not going to interrupt, or I'm not going to interfere. Finally, finally, make sure those key people all have copies of your documents. You know, they just don't do any good if you don't have them or you can't find them when you need them. And I'm a really big proponent of telling your family and friends that they can find copies of your documents in the glove box of your cars or your favorite suitcase. And tell your healthcare agent to keep a copy in his or her glove box or in his or her suitcase. They'll be available 99% of the time that way. They're no good if they're not available. The safety deposit box is no place for these documents. So, many of you have been concerned or have asked, will my directives be honored at these Catholic controlled facilities? Well, so far, we don't have any evidence that they're not being honored. We don't have any examples that providers are not being honored, but it's not unlikely that a case involving the removal or withdrawal of nutrition and hydration from someone in a persistent vegetative state, now I'm talking about something like Theresa, that kind of situation. It's not unlikely that a situation like that could occur and the Catholic provider could deny the removal of the nutrition and hydration. That's probably the most likely thing that would happen. The facility would say we can't do that because it's against our Catholic teachings and values. In situations like that, when they get to that level, there's usually some publicity or controversy, and it comes to the attention of the local bishop. We have a relatively new local bishop here in Western Washington, the Reverend Archbishop Sartain. And this particular archbishop is a bit of an activist archbishop. And I'll give you a couple of examples. A couple of years ago, well, it wasn't that long ago actually, he directed Peace Health St. Joe's to stop performing lab services for Planned Parenthood Mount Baker in Bellingham. Now, Peace Health Mount Baker didn't stop doing that, and it's because their donors told them if they did that, they'd stop giving them money. So, but the Archbishop actually told the provider to stop doing it. The Archbishop was also involved in the firing of the gay man teaching on the east side of the Catholic school who was fired after he got married to his longtime partner. He also directed his parishes to post petitions for the legislation that would have repealed gay marriage in Washington. And one Catholic parishioner that I know told me that the petition in his church was posted in a broom closet. But it was posted. So these actions by this archbishop that we now have in Western Washington indicate that he's a little bit conservative compared to his predecessors. And it concerns me that we have a conservative archbishop, because if a situation like a persistent vegetative state occurs and there's some controversy within the family, I'm not sure what will happen. So will your advance directive be honored? Probably. But it may not be honored in a situation where there's a controversy within the family, especially one involving the removal of life-sustaining treatment. Also, when you get to the point where you're very frail and elderly, or terminally ill, or you just have a quality of life that's no longer acceptable to you, use the physician orders for life-sustaining treatment, the POLST form. This is a non-hospital medical order, much stronger than a living will, that follows you from wherever you are to the emergency room and supposedly back again. And it's supposed to be honored by the emergency medical service providers and also the emergency room physicians and medical providers there. Now, the POLST form has no agenda. You can indicate whether you want treatment or you don't want treatment. It has a couple of choices about CPR, about antibiotics, about nutrition and hydration, kind of really the big issues. But POLST is really important. So if you get to the point where you simply know you wouldn't want life-sustaining treatment, use POLST. Know the affiliations of your medical providers. You know, some of these mergers that have occurred in very stealthy ways. Margaret was alluding to how they structured the mergers in order to prevent the oversight of the Department of Health. And often you'll hear these CEOs, I've heard them myself, say, well, nothing will change. If you hear a CEO of a secular hospital tell you that nothing will change as a result of a merger with a Catholic provider, call him a liar. He or she is not telling the truth. Things change. Things changed even at Swedish, which said we're going to remain a secular provider. Now, Swedish did preserve the physician's rights to prescribe and consult related to the Death and Dignity Act, and I give them credit for that. But, as they described it, as a favor or as in respect to their Catholic partner, they stopped performing any type of abortions on the facility, or they will only perform an abortion when it's obvious the life of the mother is in immediate danger, something like that. So they did acquiesce to Providence. They are a division of Providence, and over time we'll probably see Providence and Swedish becoming more and more one entity. And that entity is not going to be more secular, trust me. It will be more Catholic. So it's important to know that. You have to understand that it's not just hospitals that fall under these Catholic directives and influence. It's clinics, it's hospices. Theresa talked about this a little bit. It's dialysis centers. It's long-term care providers, skilled nursing facilities. So if you're admitted to one of these facilities, it's important to know what the facility's policies are. Ask, find out. Another thing that you can do is you can ask your provider, if your only choice is to get care at one of these Catholic facilities like Peace Out St. Joe's in Bellingham or Southwest Medical Center in Vancouver, to ask your provider, is there anything that you're not allowed to tell me? Or is there any information or choice that I'm not being presented with as a result of your employer's affiliation with a Catholic provider? It puts that person in a difficult position, but professionally, ethically, they can't really lie to you about it. They may not be able to reveal the information, but they can at least say, well, yes, there is. And if they say yes, then you can say, well, where do you think I could get this information? Don't you, as a physician, have a professional ethical duty to refer me to somebody that will provide this information that you're not going to provide to me? That's my legal right in order to have informed consent? These are really good questions to ask when you're getting medical care at a facility where you know the affiliation is with a Catholic provider. I think that at this point, I think I'm going to try and wrap this up so we have plenty of time for questions. One of the things that I do want us to end with is that, if your choice is, if you want the option of death with dignity, don't wait until you're at death's door to start the process. It takes time. As soon as you get a terminal diagnosis, you can contact us. As soon as we know that you have a prognosis of 6 months or less to live, we can help you find the 2 physicians you need and a pharmacist to fill your prescription. Our client support volunteers, the salt of the earth, can lead you through the process and be there with you at the time, with your family. But don't wait too long. I can't tell you how many times we've talked to people in our office that have called us, and when we ask, well, when was the last time you had a meal? 5 days ago. Well, that person isn't going to live long enough to get through the waiting periods to use the Death with Dignity Act. It takes a minimum of 2 weeks, and if the person doesn't have 2 physicians already on hand, it's going to be longer than that. So, give us time. We need time to help you with the process.